হৃদরোগ এবং ক্যান্সারের কারণে সর্বাধিক মৃত্যু ঘটে। প্রধান কারণ ধূমপান। যুক্তরাজ্যের মেন্টাল হেলথ ফাউন্ডেশনের মতে নিকোটিন ব্রেইনের নার্ভগুলোকে তাৎক্ষণিকভাবে শিথিল করে। এ কারণে অনেকে মানসিক চাপে থাকলে ধূমপান করেন। অভ্যাসবশত অনেকে করেন, কিন্তু বাস্তবতা হলো ধূমপানে দীর্ঘমেয়াদী দুশ্চিন্তা কিংবা বিষণ্ণতা কমে না। তবে হুট করে ধূমপান ছেড়ে দেওয়া অত্যন্ত কষ্টসাধ্য। অধিকাংশ ক্ষেত্রেই কিছুদিনের মধ্যে এই অভ্যেস আরও বেশি করে জেঁকে ধরে। তাহলে ধূমপান ছাড়ার সবচেয়ে কার্যকরী উপায় কি হতে পারে? এখন পর্যন্ত সবচেয়ে কার্যকরী পদ্ধতি হলো ভেইপ বা সিগারেট ব্যবহার করা। জাতিসংঘের এসডিজির অন্যতম সমর্থক ইউকে হেলথ সিকিউরিটি এজেন্সি, যা পূর্বে পাবলিক হেলথ ইংল্যান্ড নামে পরিচিত ছিল, তার গবেষণায় প্রমাণিত যে ভেইপিং সাধারণ সিগারেটের চাইতে 95% কম ক্ষতিকর। কারণ সিগারেটের সবচেয়ে ক্ষতিকর দিক হলো টার, যা তামাক পোড়ানোর ফলে সৃষ্টি হয়। ভেইপে প্রধানত নিকোটিন, প্রোপাইলিন গ্লাইকল এবং ফ্লেভার থাকে, যা তাপের সাহায্যে বাষ্পে পরিণত হয়। ফলে এর থেকে টার তৈরি হয় না এবং এ কারণে শরীরে বিষাক্ত কেমিক্যাল ছড়াতে পারে না। ভেইপিং থেকে সেকেন্ড হ্যান্ড স্মোকিংয়ের সুযোগ নেই, ফলে অন্য কেউ ক্ষতিগ্রস্ত হয় না। যুক্তরাজ্যে ধূমপানের হার কমানোর জন্য অতি সম্প্রতি 10 লক্ষ ধূমপায়ীকে কুইটিং টুল হিসেবে ভেইপিং কিট প্রদান করার সিদ্ধান্ত নিয়েছে তাদের সরকার। তাহলে আজও সবার হাতে ভেইপ কেন পৌঁছে যায়নি? এর একটি বড় কারণ ভেইপিং কি তা অনেকেই জানেন না। আর যারা জানেন তাদের ধারণা ভেইপিং একটি অত্যন্ত ব্যয়বহুল অভ্যাস এবং বিলাসিতা। অথচ খেয়াল করলে দেখা যাবে সিগারেটের দাম প্রতিনিয়ত বাড়ে। পাশাপাশি ধূমপানের কারণে ক্যান্সার, হৃদরোগ, অ্যাজমা, দাঁতের ক্ষয় ইত্যাদি বিভিন্ন রোগের চিকিৎসায় সরকারের ব্যয় হয় বিপুল পরিমাণ অর্থ। অপরদিকে বিশ্বের বহু দেশেই সরকারের আয়ের নতুন এক উৎসে পরিণত হয়েছে ভেইপিং। সেন্টার ফর ইকোনমিক অ্যান্ড বিজনেস রিসার্চের তথ্য অনুযায়ী যুক্তরাজ্য সরকার ভেইপিং থেকে 2021 সালে 310 মিলিয়ন পাউন্ড আয় করেছে। এদিকে এগিয়ে আছে বিশ্বের আরও বেশ কিছু দেশ, যেমন ফিলিপাইনের কংগ্রেসে WHO প্রতিনিধি ভেইপিংয়ের সুফল সবার মাঝে ছড়িয়ে দেওয়ার জোর দাবি জানিয়েছেন। সম্প্রতি যুক্তরাষ্ট্রের চিকিৎসা পণ্যসমূহ নিয়ন্ত্রক সংস্থা FDA সিগারেটের সুফল বিবেচনা করে তা খোলা বাজারে বাজারজাতকরণের অনুমোদন দিয়েছে। এদিকে ভেইপিংকে সমর্থন দিয়ে বিশ্বে আলোড়ন তুলেছেন নিউজিল্যান্ডের সাবেক প্রধানমন্ত্রী জেসিন্ডা আর্ডার্ন। তিনি বলেন, দাম বাড়িয়ে ধূমপান বন্ধ করা সম্ভব নয়, বরং কোনো বিকল্প খুঁজে বের করতে হবে যা সিগারেটের চাইতে অনেক কম ক্ষতিকর এবং ধীরে ধীরে ধূমপানের অভ্যেস ত্যাগে সহায়তা করে। নিউজিল্যান্ডে ইতোমধ্যে ভেইপিং ফ্রেমওয়ার্কও তৈরি হয়েছে। সুইডেনে 15 বছরে ধূমপায়ীর সংখ্যা 15% থেকে 5.6% নেমে এসেছে, কারণ সেখানে ভেইপ, সিগারেট, স্নুজ ইত্যাদি ক্ষতিহ্রাস সহায়ক পণ্যের ওপর কর সিগারেটের তুলনায় মাত্র 8 থেকে 36%, যার ফলে যেসব ধূমপায়ী ধূমপান ছাড়তে চান তাদের জন্য বিকল্প পণ্য সাশ্রয়ী ও সহজলভ্য। এবারে বাংলাদেশের প্রেক্ষাপটটি দেখি। বাংলাদেশে যে কোনো ইলেকট্রনিক নিকোটিন ডেলিভারি সিস্টেম অথবা এর রিফিল আমদানি করতে 212.2% ট্যাক্স দিতে হয়। ফলে খুচরা মূল্য অনেক বেড়ে যায়। তাই ইচ্ছে থাকলেও একজন মধ্যম আয়ের মানুষের পক্ষে এদেশে সিগারেটের তুলনায় 95% কম ক্ষতিকর ভেইপিং বা সিগারেটের খরচ বহন করা দুঃসাধ্য। যুক্তরাষ্ট্রের ভার্জিনিয়া ভিত্তিক কনজিউমার চয়েস সেন্টার 2020 সালে একটি প্রতিবেদন প্রকাশ করে। সেখানে তারা বলে, যুক্তরাজ্য সহ অন্যান্য উন্নত দেশে ভেইপ বা সিগারেটের মান যেভাবে নিয়ন্ত্রণ করে, একই ধরনের মান বাংলাদেশে বজায় রাখা সম্ভব হলে 62 লক্ষাধিক মানুষ সিগারেট ছেড়ে ভেইপ ব্যবহার করবে। অপ্রাপ্ত বয়স্কদের উপর নিষেধাজ্ঞা, সবার হাতের নাগালে এনে দেয়া ইত্যাদি নীতিমালা তৈরি ও বাস্তবায়ন করতে পারলে 2040 সালের মধ্যে তামাকমুক্ত বাংলাদেশ গড়ার যে স্বপ্ন মাননীয় প্রধানমন্ত্রী দেখেছেন, সেটি সফল করার পথে আমরা অনেকটাই এগিয়ে যেতে পারব।
Good afternoon, everyone. Welcome to the THR Summit Bangladesh 2023. I'm glad to see all of you here. I'm Azra Mahmood, and I will be your host for the day. Today's summit has been arranged by Voice of Vapors Bangladesh along with the Asia Harm Reduction Alliance. The Honorable Prime Minister of Bangladesh has called for a country to be smoke-free by 2040, meaning a smoking prevalence of 5% or less in the adult population. In this multi-stakeholder dialogue today, we will discuss the science behind tobacco harm reduction with experts around the world and also hear the voice of consumers to determine the best course of action for Bangladesh to achieve a smoke-free nation. We will also evaluate the best practices in other countries such as Sweden, New Zealand, and the United Kingdom. But what is THR? THR, or tobacco harm reduction, is a scientifically proven method that has helped many progressive nations of the world to reduce the smoking incidence and move towards a smoke-free nation. The United Kingdom, New Zealand, Sweden, and Canada are only a few examples of a successful THR framework. So now the question is, what can we learn from these case studies? Would it be possible to implement a THR framework in Bangladesh like the UK or New Zealand? Well, these are something we will be discussing today. The lives of 1.4 billion adult smokers worldwide are at stake. This summit can help find ways to save lives. The summit will help us understand how we can formulate a progressive tobacco control plan through the full integration of harm reduction strategies as called for in Article 1D of the WHO Framework Convention on Tobacco Control. Firstly, to provide speech, we have Dr. Dylan Human, who is the CEO of Health Diplomats and former Secretary General of the World Medical Association. Dr. Dylan Human was also an advisor to 3 Director Generals of the World Health Organization and to the former Secretary General of the United Nations, Ban Ki-moon. Also joining alongside him is Masuduzzaman, the convener of Voice of Vapors Bangladesh. With a round of applause, please welcome on stage Dr. Dylan Human and Masuduzzaman.
Thank you, Asra. And on behalf of all of the international guests here in Bangladesh, thank you for your warmth and hospitality, which we always experience when we come to Bangladesh. We also want to convey our feelings for those who have been affected by the cyclone, and thank all of the hundreds of participants from Voice of Vapors to come today. Shuman, thank you that you've
so much.
Invited us to your home.
Thank you so much for being here.
Would you like to say a few words of welcome?
Thank you everyone for joining here, and I hope that it will be a very truly learning experience for all of us here, from experts all over the world. They will be joining us from online. Also, Dr. Dylan Human and others have come here. So thank you for being here.
Thank you, Shuman. Ladies and gentlemen, it gives me great pleasure to introduce to you our first keynote speaker. Dr. Derek Yach was a cabinet minister on the World Health Organization at the time when the Framework Convention on Tobacco Control was being developed. And he's played a key role in many fields of what we call non-communicable disease. Derek has worked as an academic, as a professor at the University of Yale. He's also worked in the food industry, where he helped the big company PepsiCo change the whole product portfolio. And he's been an ardent supporter and a tireless warrior in the field of tobacco control. He's also published widely in most peer-reviewed journals in public health, and it's our honor to welcome him. First, we will look at his opening address, and then he will be joining us online, and I have a surprise for you. But first, we will look at Derek's opening address online.
So, hello, Derek. How do you see the Bangladesh progress in tobacco control?
Well, let me start off by expressing my prayers to the people of Bangladesh as they recover from the devastating cyclone Maka. Well, I think it's an important question, but let's put it in context. Bangladesh has shown remarkable leadership in public health with a very strong focus on equity. And many people in tobacco control be unaware that over the last 50 years, BRAC and the Grameen Bank under the Nobel Prize winner Muhammad Yunus propelled the country's progress from focusing on the local to the global. It becomes no surprise then that when it came to looking at international issues to address tobacco, Bangladesh was one of the very first to sign the Framework Convention. What we've seen really over the last 3 decades is that Bangladesh has undergone what many call an economic transformation. The result? A dramatic decline in poverty and a shift from Bangladesh being defined as a low middle income country to middle income country. It's basically become the envy of the developing world. One of the consequences of this rapid economic transition has been a dramatic shift away from infectious diseases to non-communicable diseases as the leading causes of death. And in that context, tobacco plays an important role in driving the shift to cancers, cardiovascular disease, and lung diseases. So let's just look at what is the actual data of progress in Bangladesh. Well, they find themselves in a situation where the United Kingdom was 40 years ago. About 45% of men and 25% of women currently use tobacco, with an equal distribution of combustible and smokeless toxic products. And maybe more worrying is that 45% of male doctors and dentists smoke. Typically, we know that countries witness a decline in smoking rate among adults about a decade after the health professionals first quit. And the reasons for this are many. Health professionals can either motivate their patients to give up or not. They can advocate for effective government policies or not. They can conduct the research needed to drive policy or not. And my concern is probably the not category has been bigger in Bangladesh. In contrast, the UK doctors in the 60s, when they first were confronted with the evidence that tobacco kills, dramatically shifted their consumption, and half of them were smoking a decade after the first reports come out. That's what's still needed in Bangladesh. So we might ask, why has Bangladesh fallen short of its ambition to reduce tobacco-related deaths? How can the lost time be compensated for if the country is to achieve the Prime Minister's stated goal of becoming a smoke-free country by 2040? Is the slowdown due to the undue influence of the industry that has made Bangladesh the 8th largest consumer of tobacco, selling 92 billion tobacco sticks a year? It sells significant amounts of smokeless products like Zardas and Gul, and huge volumes of bidis. Is it because the voices of the farmers who've worked tirelessly have resulted in an increase in tobacco cultivation by 50% in the last 10 years against almost every other international trend going in the opposite direction? Or is it because the health professionals, as I mentioned before, have yet to speak up and are continuing to smoke at high levels? In fact, not only are they smoking at the same levels in the population, they have yet to include nicotine replacement therapy onto the National Essential Medicine list, unlike most countries in the world and unlike the strong recommendations of WHO. I think all of these factors play a role. But let's remember, Bangladesh possesses the means to significantly reduce tobacco-related deaths if it was to follow the policies that are already in place in a number of countries. What are the stakes involved? Well, we know that tobacco kills 160,000 people in Bangladesh every year. That represents nearly 1 in 5 deaths nationwide. And these deaths occur due to lung and oral cancer, lung and heart disease, tuberculosis, and remember Bangladesh still has a very large tuberculosis load, and tragically among individuals with severe mental illness. They cause immense pain and suffering. And to put that in context, let's remember that about 30,000 people died during the entire COVID pandemic. So the figure of 160,000 deaths from tobacco every year is huge, even if we assume that the 30,000 COVID deaths may be out by several orders of magnitude. If current trends continue, even if we assume there's a modest improvement in tobacco control, Bangladesh is set to witness 4 million tobacco-related deaths between 2025 and 2060. That's the bad news. But if they were to embrace a comprehensive range of reduced risk tobacco products that we'll hear extensively discussed during this meeting, and obviously you know that they include everything from e-cigarettes to heat-not-burn products to nicotine pouches to snus, if they would do that and do it at a fast rate, we could bring the 4 million deaths down by 50% to 2 million over the next few decades. There is no other public health intervention that comes close to achieving such a significant impact. In the year leading up to COP10, Bangladesh could regain its international leadership and its steam in terms of its economic growth. They could copy the examples of the United Kingdom, Sweden, South Africa, Japan, that we'll actually hear about, I'm sure. They could look nearby to Malaysia and Pakistan, where e-cigarettes are legal, or to the UAE, where we're seeing use displacing tobacco products. Importantly, the transformation that's been achieved in the economy now needs to be taken up as a transformation in the tobacco sector. The tobacco legacy sector is one of the few parts yet untouched by the huge transformation. And remember that the transformation of the country's economy has been based on better science, research and development, innovation, all the core elements that come together to actually drive reduced risk products. If they succeed, I have no doubt that Bangladesh will achieve the esteem that it has always had in other areas of global health. And the beneficiaries, in terms of smokers, the users of smokeless tobacco products and their families, will be immensely grateful and the economy will benefit. I hope that this meeting leads to an urgent sense of going down the path of transforming the tobacco sector in the way in which you've transformed the rest of your economy. Thank you.
Derek, I would like you to spend 5 to 10 minutes now telling us about the history of the Framework Convention on Tobacco Control, or the FCTC, how it was established, and also your personal involvement with its development.
Well, thanks, Jessica. When I was at WHO, Gro Harlem Brundtland became the Director General, and she felt very strongly, having been the Prime Minister of Norway, at a time when the environmental treaties that we all now know so well, the ones on climate change, reducing greenhouse gases and so on, were brought to the fore, that the way to deal with complicated issues across national borders was through a treaty. And so I was given the authority to move ahead and build a team to actually move the process of the Framework Convention ahead. It took us 5 years. It involved all member states coming together 5, 6, 7 times in Geneva, in what became known as the University of Tobacco Control. People got trained and groomed in why are we doing this, what are the benefits, the legal issues involved, and drew upon the best practices around the world at the time, whether it was advertising controls, the role of taxes, bans on smoking in public places, and so on. And the negotiation was rigorous. 5 years sounds a long time, but actually it was pretty short in terms of treaties. And in the end, a unanimous agreed document came out, of which Bangladesh was a key player, and as I said earlier, one of the early signatories. Some of the key elements to remember. First, the definition that we came up with, not we, but the member states, was that tobacco control includes all the elements we normally consider, including explicitly harm reduction. And the view certainly then was that while we may not have all the means to drive a harm reduction agenda, we had some. Nicotine replacement therapy is, after all, an example of harm reduction. It separates nicotine, which doesn't kill you and actually saves your life, from the stuff that kills you, which later we knew was basically all the combustible products. There were other values to actually having it in the definition. It was shown that even though it may not be used immediately, that was 2003 to 4, 5, in time, it may be drawn upon as the science evolves. Well, the science has evolved. And now I believe very strongly that it's a time for the rethink by WHO to look at the examples around the world. Other components of the Framework Convention that were misinterpreted at the time included a very famous article called Article 5.3, which basically says, and people can read the text, that in dealing with the tobacco industry, governments are cautioned about ensuring that there's no conflict of interest and that they do so without involving the tobacco industry in the direct policy-making process. The text nowhere says anything about a prohibition or ban on the engagement by governments with the tobacco industry or any tobacco entity. That was not in the text. Later, a bunch of guidelines were issued by the WHO staff, which actually were not in accordance with the text. They had no authority to really do it, according to many international lawyers who've studied the text. But we need to remember that what's happened since is that the other treaties, the environmental treaties, climate change, all of these have moved to what is called international modern governance, which basically means deeper stakeholder involvement, wider involvement of the private sector, of non-profits. And basically the argument being made is that any entity with a material interest to solve the problem, be it a social or environmental problem, needs to be at the table when the issue is being discussed. You obviously don't want the hands of corporates writing text, whether it's in the environmental field, the transport, the oil and gas field, or in the pharmaceutical field. But you must know what their science tells you, what they believe is possible and feasible, and how you can get the best out of it. All of that has been eliminated over the last few years during the process of the Conference of the Parties, which is the process that takes the text down to government action. And so what do we have today? Very few nonprofits, in fact, have an active voice during the process. The industry, and industry is defined very broadly, almost down to any fourth generation involvement, is banned, prohibited, dismissed. The media engagement in the process is minimal, particularly if you compare it to the really exciting, dramatic involvement of the media, the private sector, the nonprofits in COP26 focusing on climate change, or what will be COP27 and 28 advancing these processes in Egypt and later in the UAE. If we look down the line, the question might be asked, so has the Framework Convention achieved any positive outcomes? And my view is absolutely yes. There's no question that some of the progress we made by countries in raising their level of taxes, the most powerful means of addressing consumption, in increasing advertising bans, and a range of other policies would not have happened without the power of a group of countries coming together and pushing each other to go in the right direction. But some areas have not seen the progress we want. Smoking cessation remains in the doldrums. Most low-middle income countries haven't actually engaged through their clinicians the patients who desperately need help. These would be smokers being seen every single day in clinics around the world, maybe with an early symptom of chronic bronchitis that will lead to emphysema, maybe with signs or symptoms of early stage cancer that if detected early could be cured, or cardiovascular disease or tuberculosis. There is virtually no support in most of the low-middle income countries to have a sharp focus on that. And that's where there's a real opportunity. Of course, the other aspect of the Framework Convention that hasn't played out is the text, as I said, on harm reduction. And in my view, that represents the greatest opportunity for WHO to put the world on track and for each country to take the progress that's needed.
So Derek, you mentioned Article 5.3 and the misinterpretation of the text. This is very important. How could this be costing us lives?
Well, you know, I've always been very aware that if the right people are not at the table at the time, decisions about life-saving opportunities are missed. Can you imagine if the pharmaceutical industry had been banned from engagement with WHO because there's a conflict of interest in their products, while the COVID vaccine discussions were happening? The WHO would have no clue that there are alternatives and means of cutting the death rate long-term dramatically. They had to be at the table, they had to be there to give this insight. It's up to WHO to judge how interpreted. The lack of direct engagement between tobacco, vaping, snus, pouch companies and the public health sector means they are deprived on hearing about the advances in science that can save lives. And instead, they're looking to tobacco control advocates who may be well-meaning, do not come out of a field or grounding in deep science or in some of the advances in the innovation. And instead, they are developing policies that exclude and ban them. Worse, we know that when there's a ban on something that could save lives, like e-cigarettes, the smokers, from the studies we have out there, move back or continue smoking, believing that is a safer or protected way of continuing, better from an e-cigarette, which is going to cause a range of terrible problems, which of course it doesn't do.
I'd like to now speak about harm reduction strategies for Bangladesh and low middle income countries. So Derek, what would you regard as tobacco control 1.0 and subsequently tobacco control 2.0, factoring in tobacco control and tobacco harm reduction together?
Well, there's a great synergy between some of the elements of the Framework Convention, particularly the most powerful ones. I'd say taxes, advertising bans, bans in public places, and cessation. For each of those, I see that there's an opportunity for harm reduction to also have a regulatory place, but the principle should be that we should be regulating proportionate to the risk of the product. Now, we know that products like e-cigarettes or nicotine pouches constitute a minimal risk to the adult population, probably close to zero, but they help people move from a cigarette out of the toxic product. The regulatory environment going forward needs to make it easier for a smoker or user of toxic smokeless products to make that transition. What does that mean? It means you need a good price differential between the reduced risk products and the combustible products. It must be tougher to buy a combustible cigarette in terms of price. The advertising and marketing needs to reflect that differential too. It needs to not just talk about the dangers of vapes and make them equivalent to cigarettes, but be very clear about the benefits of what it'll mean in terms of reduced risk to exposure and ultimately to death. Smoking in public places, I see we need to maybe to be more flexible. Obviously, nicotine pouches and snus are perfect examples of products that could be consumed everywhere legally. There's no ban and no probability of a ban. But vapes also need to have a place, vape users, where they can actually use their products in an indoor environment. Otherwise, they'll probably walk outside and continue smoking. And then finally, cessation. We've seen from the UK government that if you invest in vapes as being in the center and in all the cessation clinics, and the message being given by general practitioners across the National Health Services, you need to include vapes as part of your armamentarium, knowing that the evidence shows that people are more likely to quit, maybe even double their quit rate if they use a vape, as opposed to if they use a patch or gum. And the reason is because they appeal more to many of the sensory desires of a smoker, which shows another problem that we have not based our regulation on what the consumers, what the actual users of products want, need, or are going to use. Instead, we sat in Geneva and came up with great laws on the books, which simply don't work when you get to the streets.
And what would be your assessment of the potential lives saved if harm-reduced products were in fact to be allowed as an alternative to smokers globally, but also in Bangladesh?
Well, globally, the projections are that we're going to be getting up to about 6.5 million deaths a year by the late 50s, 2060s. That figure could be halved if we were to move people faster to reduced risk products and do other things. People say, is that realistic? Yes, of course it's realistic. We're talking about a few decades. If you look at consumer goods, many that were never on the market, we didn't have any notion there'd be smartphones, cell phones, the internet 20, 30 years ago. It was very unlikely. Well, today it's become ubiquitous. There's no reason why the consumer products-driven approach of a combination of both vapes and pouches and snus could actually follow the same and maybe even a faster trajectory, because there's a huge demand by smokers to find better products for themselves. And the numbers, as I said before, the 160,000 deaths a year, a staggering number, multiplied over the time span of 2025 to 2060 of 4 million deaths in that period, could be cut by a half, maybe even more.
And what role do you think that e-cigarettes specifically can play in Bangladesh?
Well, I mentioned that about 50% of the market use combustibles at the moment, and they include some very cheap cigarettes, by the way, BDs, more commercial cigarettes, so quite a range. And 50% use a range of smokeless products. Some are unique to Bangladesh, others are more traditionally seen in other Asian markets. I think, first of all, in each of those two markets, there are going to be different opportunities. The most likely opportunity for the combustible user, particularly those in the middle and upper social classes, certainly would be vapes, maybe heat-not-burn products. Huge opportunity because they would be affordable. They would be similar to the custom of how they use their products. In the smokeless category, snus and nicotine pouches must have a huge opportunity to take off and displace the current toxic products. But there will be those who are going to want to use both. A vape, for example, I think is very well used in home settings, out in the street when people are out and about. Many businesses in the workplace have restricted vapes. In that setting, during the day when you can't use a vape, having access to a nicotine pouch to maintain your smoke-free status seems sensible. So down the line, I would see a mixed use, vapes initially appealing particularly to the current combustible users. It's almost half of the users in Bangladesh, whereas the nicotine pouches appealing to the big smokeless category.
And as a former WHO leader, what would be your best advice for the Ministry of Health and the Prime Minister of Bangladesh when it comes to how best to prevent and control tobacco-related disease and premature death in this country?
Well, it's very bold for me to give advice to the President and the Prime Minister. I think the main advice I would give to them is to say, you have set a bold goal of ending smoking and becoming smoke-free by 2040. Becoming smoke-free in technical term means less than 5% of the population smoke. That is a massive challenge to achieve by 2040. Sweden is about to achieve that, to become the first country in the world to achieve it. But remember, it was 40, 50 years ago that they were smoking at the rates that you are in Bangladesh. If you want to accelerate the process and actually get to that 2040 target, you have to double down and remove all regulatory barriers to access to the full range of harm reduction products. You as the Prime Minister and the President need to speak out about combustible cigarettes and toxic tobacco products and be very careful to make sure that you don't demonize nicotine itself. Dismiss the myth that nicotine causes cancer or that nicotine has other adverse effects, when by and large it doesn't. I think if you did those things and you then let the market forces that are doing so well in Bangladesh driving you to levels of development that were almost unthinkable 2 decades ago, you would see that the market would be able to push the access to reduced risk products in a way in which there isn't a big cost that gets imposed on government and government finance. It's not like trying to get NRTs out of the door, other cessation, which requires usually on public finance. Once you release the regulatory power that you have to make it easier for people to have access to safety-approved products in the harm reduction place, the market forces will do the rest for you. They will do the distribution and reach the people and support them. And in that way, you may have a chance of reaching the 2040 target. Otherwise, there is no possible way of getting close to that target.
Thank you, Derek.
You did already mention this already about Sweden, but there are other countries.
Thank you, Derek. And we are all sitting here in the hall enjoying your remarks. Shuman, I'd like to just tell you more about Derek, our keynote speaker. He's a wild water swimmer. So he's swum the English Channel a few times. He's also swum the distance between Cape Town and Robben Island, the Strait of Medina. So he's been a very healthy role model for us all. And indeed, Derek would have been with us here in Bangladesh had he not, at this stage of his life, suddenly fallen ill, and he must be near a hospital. So we're indeed so grateful that Derek has made himself available. It's 5 a.m. in the United States, and here he is live. Could we give him a round of applause?
Thank you very much, Derek, for your time and for the insight and for the information you shared. I'm sure that we can, if we can make use of it, we can actually progress towards our goal. Thank you very much.
Derek, in your last response, you said what you would advise the Honorable Prime Minister in Bangladesh in her goal to move the country towards smoke-free in 2040. Can I just ask you, as somebody who was central to the development of the Framework Convention, is it time that the Framework Convention alone will not achieve that goal for any of the countries?
Thanks, Dylan, and again, pleasure to be with you in spirit and by remotely. I think that the Framework Convention contains all the elements we need. As I stressed earlier, remembering that the very definition of tobacco control in Article 1D spells out that harm reduction is part of tobacco control. And in fact, it always has been. If you think back decades, the first form of harm reduction physicians' practice was to tell their smoking friends, smoke less. That's the first form of harm reduction. If you move from a pack a day of cigarettes to 5 a day, you cut your risks by multiples, huge amounts. Something when I was at WHO, we weren't actually able to talk about because the mantra was, there's no way to consume a cigarette safely, which is theoretically true, but when you compare it to the massive risks of a pack and a half to 5 a day, we're talking about millions of lives being saved. So I would say, Dylan, in essence, the Framework Convention has a package of activities. The question is, first of all, the political will to move on harm reduction would be the biggest breakthrough in accelerating change. And secondly, taking the theoretical text that looks fantastic in Geneva to the streets of Bangladesh, to all the communities, in reality means involving physicians, health workers, the population on the ground, starting with things around providing advice, providing cessation, providing harm reduction. That element has yet to actually happen.
Thank you, Derek. And then a question about economics. Some context first. Bangladesh will have a general election in January 2024. And at the same time, they will be looking at a macroeconomic 5-year plan. The question is whether tobacco harm reduction and its economic implications should be included in such a plan.
Yes, I think it should be. And I think back to my days when we were in South Africa during the very first Mandela government. The reconstruction and development plan of the country addressed tobacco control alongside the macro issues of reducing the enormous consequences of apartheid on people's lives. When you think about it in that context, it rose to being an important issue, both because of the economic cost of tobacco then and projected forward, and the economic benefits that tobacco brings as well. So let's just think about Bangladesh. The latest estimates I've seen suggest that about 1.5% of GDP is lost due to the effect of tobacco in Bangladesh, which is a significant amount. It's in dollar terms, it's about $4 billion. That is in healthcare costs, loss of productivity, in a country moving at a stunning GDP rate, increased growth of 5%, about the best in the world. You don't want to hold anything back. You want maximum productivity of the workforce. You want to reduce long-term the healthcare costs associated with tobacco. But think on the other side. Industry pays a significant amount of the tax burden into the fiscus of the Bangladesh government. And while you might say, well, we're going to lose that, in fact, if you grow the harm reduction category, those very same companies will be paying maybe a smaller proportion per unit, but overall, a reasonable amount to continue to provide economic support. But what they'll also be doing is they'll be investing in innovation in terms of technology and capacity. And the innovation that usually it takes to develop harm reduction has enormous spillover effects into health sciences. Health sciences is seen by Bangladesh as one of its key growth areas for the future. And so I would say that it's in the macroeconomic plan, support to accelerate the transition from combustibles and smokeless into innovative products and the knock-on products that come out of the pharmaceutical sector, and reducing the direct healthcare costs can only be good for the economy.
Thank you, Derek. And then a last question for the Voice of Vapors. And Schumann will testify there about 7,500 members
Yes.
in the Voice of Vapors. In the rest of the world, we've become accustomed to the anti-tobacco harm reduction calls and even organized lobbying against consumers like yourself and consumer advocates like yourself. Derek, what advice would you have for Voice of Vapors and the members who are here today in droves? How do they arm themselves and how do they win this diplomatic battle?
Well, again, going back to our common South African roots, I think we can take inspiration from the Nothing for Us, Without Us movement of the HIV/AIDS activists, those living with AIDS, those advocating for change that came out of South Africa. It was thought unthinkable that the voices of NGOs, of people who have the problem, who are stressing it, would not only be able to bring about government change, but bring about global change in the trade regime of the world through the way we deal with access to affordable antiretrovirals. There is no reason to believe that the same couldn't happen if the voice of vapors was accelerated, made stronger, more unified. Of course, it's always got to be science-based, but that's really for the scientists to do more. I think it's got to be passion-based. It's got to be urgency-based. And with those actions of passion and urgency, there's no question that they could achieve goals that would allow harm reduction products to be accessible on the market in Bangladesh legally and supported by governmental positions, as we're starting to see that happen in so many other countries we'll hear about.
Ladies and gentlemen, would you join me in a warm round of applause for Derek, all the way from New York? Thank you very much for joining us at such an early hour. Thank you very much, Derek.
Thank you very much.
Thank you. Pleasure.
Friends, now we have the privilege to introduce to you Professor Mariva Glover, and I'll ask Azra to do the honors.
Thank you very much. Now we will move on to our first session of the day. The first session will be on global tobacco and THR policy, where Professor Dr. Mariva Glover will be talking about how tobacco harm reduction can prevent tobacco-related disease and premature death in Asia using insights from the New Zealand model, and can developing nations such as Bangladesh implement a similar framework.
Thank you, Azra.
Good afternoon, and thank you, Delon, and the Asia Harm Reduction Alliance and Voices of Vapors for inviting me to be here. It's a real honor and very, very interesting. My first time to Bangladesh. So I've worked in public health for over 30 years and tobacco control for that amount of time as well. My training was in psychology. I'm a behavioral scientist, and my doctorate was on smoking cessation. These are my disclosures. My center is funded by the Foundation for a Smoke-Free World, and that was when Derek Yak was the president there. So interestingly, New Zealand and Bangladesh were early ratifiers of the Framework Convention on Tobacco Control. Actually, we signed at the same time. New Zealand, however, had already implemented a comprehensive tobacco control program back in 1990, the first country in the world to do so. And by comprehensive, I mean it was covering like bans on advertising, smoke-free environments, all sorts of different strategies across the whole realm. Advertising, health education, educating the public that smoking was harmful and the government would like you to stop smoking. So it sort of set a model even for the Framework Convention on Tobacco Control. And over the last 30 years, since 1990, we have passed several amendments strengthening and extending the tobacco control measures. But even though we had many measures and strategies in place, smoking prevalence reduced very slowly. So in 1992, 27% of 15 years and older were smoking. 20 years later, it had reduced about 10% to 18.4%. And then another 10 years later, to 2021, we were down to 9.2% smoking prevalence. So very, very slow. In 2000, the government implemented smoking cessation programs, a national free quitline service. In 2006, we subsidized people's access to nicotine patches and gum. And even all of that, even having local clinics to offer cessation support, it was only about 1% per year on average reduction in smoking prevalence. This has all changed since the introduction of vaping to New Zealand. So this graph I'm going to show you is very important evidence showing how vaping has sped up the reduction of smoking in New Zealand. The top blue line, the light blue line, this shows the reduction in regular smoking. So regular is anything less than every month, weekly, and including daily. So from 2011-12, you can see it going along around about 2017, and 2015 is when vaping sort of started to take off, but we weren't measuring it then. And then you can see it really drop off. So in the video at the opening, there was our Prime Minister at the time, Jacinda Ardern. That 2019-20 is about when she went on TV and said, we are adopting vaping. If you cannot quit on your own or with many of the patches, gum, medications, then I would encourage you to switch to vaping. And the government passed regulation, and they've been running a national social media, TV, across media, a Vape to Quit Strong campaign, encouraging everybody to switch if they could not quit another way. And you can see that just far more rapidly, it drops down there. Now the brown line is daily smoking. Daily smoking is important because it's really daily smoking over 25, 30 years that leads to the death and premature death of people who smoke long term. The dark blue line, that shows you at least monthly vaping. So you can see vaping, the vaping prevalence increasing, and it's almost kind of, looks like a nice perfect picture there of vaping displacing smoking. The orange line is daily vaping, and in 2022, I can't quite see that far, 21-22, daily vaping was up to 8%. And the smoking prevalence was also at 8%. So quite a good picture to show you how vaping and other harm-reduced products can also bring about this effect. If you look at Japan, and you will see a similar picture with heated tobacco products there, and I think we're going to see some Swedish figures later on. The USA has a similar graph like this, and the UK. Now that data, by the way, does not take into account how many people were both smoking and vaping, and it's cross-sectional, so it does not prove a causal effect, but the association is fairly obvious there. And we have other research results suggesting that vaping displaces smoking. However, New Zealand's national achievement of only 8% smoking hides the fact that some groups are being left behind. I think this is very important for you here in Bangladesh. This graph shows daily smoking and it's split across the population by quintile or income level. So quintile number 1, the lower ones on the graph, that's the 20% of the population on the highest income. And 5, that's the 20% on the lowest income. So you can see here that 60% of the population, quintiles 1 to 3, have a daily smoking prevalence of around 5%. 5%, that's New Zealand's goal, 5% or below by 2025. So we don't have very long to go. But we're nearly there, and some of the higher income people are already there. But 20% on the lowest income, quintile 5, have disproportionately high smoking rates. Daily smoking among our poorest women, very different from Bangladesh. In New Zealand, our women have high smoking rates. Same as men, really. 20%, so our women, daily smoking is 16%. And for males, in the poorest group, it is 19%. Another left behind group are Indigenous Māori. So Māori people in New Zealand, of which I am, make up 15% of the population, so quite a sizable group, and also we have quite a bit of political power and many politicians in Parliament. Unfortunately, tobacco was introduced to New Zealand. We did not have our own, plant with nicotine, no plant with nicotine. It was introduced by the British and the whalers around about from 1780 and in the early 1800s. When they brought tobacco to New Zealand, and same with Australia and the US and Canada, they used it as an item of trade, and they encouraged both men and women to smoke. So very unlike other women in the world, Māori women have been smoking for around about 200 years. When you have both parents smoking, the mother and the father, you have a much higher rate of uptake among children. So this pattern of us being left behind, it's been like that for a long time. The light blue line shows daily smoking among Māori women, and for all the time I've worked in this area, Māori women have had the highest smoking rate in New Zealand. And it was only last year, this is the first time that Māori women's smoking rates have dropped below Māori men, the brown line, daily smoking. But look where the New Zealand European and other people who have over the 200 years come to live in New Zealand, look where they are. The dark blue line, 6%, this daily smoking is down to 6%. They're almost at 5% or below. That was the women, 3 times lower than Māori women, and similarly for New Zealand, European and other men, they're down to 8% already, 2.6 times lower than Māori men. It is very important from a harm reduction approach to consider how policies will affect these left behind groups. Harm reduction isn't just about moving people from a high-risk behaviour to a lower-risk behaviour. Harm reduction is also concerned about reducing the harm that might come from policies, like what happened when the USA banned alcohol in the 1920s, prohibition. A harm reduction approach does not support implementing a policy that is going to introduce some other harm, such as banning vaping or the harm reduction products. Poor policies like banning the lower risk alternatives to smoking can result in a black market and the associated crime that goes with a black market, injury, convictions, and imprisonment. In New Zealand, the people being caught and imprisoned are, unfortunately, the marginalised groups and a lot of Māori Indigenous people. New Zealand has very, very high tax on tobacco cigarettes. It got so high that cigarettes were too expensive for the poorest people to buy them. And since that time, we have had, it's like the wild, wild west in America. Our shops are being robbed, they're stealing cars and driving into the front of shops, taking tobacco. It's happening every day. Crime it's just out of control. So this is a good kind of warning for you what can happen when you implement a really harsh ban or a policy that makes it hard for the people who smoke to get access to alternatives. Policies that increase poverty or marginalisation and crime will have a serious and harmful effect on our Indigenous people because of our high smoking rates and because we already make up over half the people imprisoned in New Zealand. Over 60% of the women imprisoned in New Zealand are Māori. This should be an international shame. So in conclusion, historical context is important for understanding smoking prevalence among different groups. Different social, cultural, and political, and for Bangladesh, I would say also different religions, these contexts determine the disparities within countries for smoking prevalence. Times have changed, and the products have changed as well, and we need to keep up with the innovation that is happening. Risk-reduced tobacco and nicotine products, the products with the lowest risk that are acceptable to the consumer, could, in time, eliminate smoking-related diseases. Beware of policies for which there are no scientific trials in real life communities for which that record the adverse and negative consequences for communities. In New Zealand, we have implemented some far-reaching, radical new policies to get rid of smoking, but there are no trials to support those policies, and there's no recording of the consequences as yet. Beware campaigns demanding prohibition, especially in countries with large disparities in smoking prevalence across different groups and income level, particularly. The other group to remember are people with mental health conditions. Smoking prevalence is typically higher among them as well. Thank you very much.
Mariva, if you wouldn't mind just to stand here and answer just one or two questions. We will have a panel discussion at the end of our session anyway. But to your last point about beware campaigns calling for prohibition, that's exactly the situation that you have in Bangladesh. Is that right, Shuman?
Absolutely, absolutely.
And if you recall perhaps how this was averted in New Zealand, because there was also talk at the time in New Zealand of a total ban on vaping products. How did you manage to stop that and turn it around?
So there were a few scientists along with myself who looked at vaping very early on, and it helped. Some of them were doctors, some of them were scientists, academics. We had tried everything. We had even tried to get Swedish snus accepted in New Zealand and regulated, but we couldn't get that across. The main argument against that was, oh, it's a cultural thing, it's specific to Sweden. And I was chair of End Smoking NZ, so a group of people who had worked in tobacco control and doctors. We lobbied for snus, we couldn't get it in. We just had to keep looking for something. And then vaping, which Honlik from China invented the vaporizer in 2003. So we're talking 20 years ago. And some of our scientists began to have a look at it. One person I worked with, Dr. Murray Logerson, he conducted the very first trial and test of the Ruyan cigarette to look at the toxins in it. So we began to do our own research in New Zealand and randomized controlled trials, seeing if this could help people to quit. So we had some local evidence. That did help, I must say. And we had consumer groups start up. The consumer voice is very, very important. It's very important for the government to hear from the consumer about what's happening. So we had scientists, academics, and consumers. Many people in the media in New Zealand were smokers. So they cottoned on very early because they switched to vaping, and they also helped. I think it just depends who you have working in your Ministry of Health as well, and how open they are. And I guess the biggest thing is to focus on the death and disease, really focus on those numbers. If you want to bring that down, with all of the other measures many countries have tried, the fastest way to bring that down is by offering people a very lower risk alternative to smoking. There are now randomized controlled trials that have shown that vaping is more effective than the patch at helping people to stop smoking. So evidence, consumers, media, and educating your public, educating your politicians, this will do it. This will save lives.
May I ask you to join me in a warm round of applause to Mariva. She will be part of the panel discussion at the end of the session. Thank you so much, Mariva. If I may beg your forgiveness for 2 minutes, we just want to move the chairs to the side before we look at the next set of slides. 2 minutes, please.
আলগা নিয়ে আসলাম।
Thank you very much, Professor Dr. Mariwa Glover. That indeed was very informative. I'd like to mention that Professor Dr. Mariwa Glover is the director of the Center of Research and Excellence, Indigenous Sovereignty and Smoking based in Auckland, and the editor of the International Harm Reduction Journal. Can we please have another round of applause for Professor Dr. Mariwa Glover? Thank you very much. And now moving on to our next session on THR Science, where Professor Dr. Konstantinos Farsalinos and Professor Dr. Mihaela Raiscu will discuss the science behind THR products and policies. Professor Dr. Konstantinos Farsalinos is a cardiologist and research fellow at the Department of Pharmacy, University of Patras, Greece, and a researcher at the National School of Public Health, Greece. He is also the most cited harm reduction researcher in the world with over 70 publications. And Professor Dr. Mihaela Raiscu, who will be joining us online, is a dentist and a member of the Faculty of Dental Medicine at the Tito Maiorescu University, Bucharest. Can we please have a round of applause for Dr. Konstantinos Farsalinos and Dr. Mihaela Raiscu.
Hello everyone, thank you very much for the invitation. I just want to update that I have about 100 published studies in the international scientific literature concerning tobacco harm reduction, mainly electronic cigarettes and heated tobacco products. So I'm going to start with the smoke-free vision that you also have in Bangladesh. We also have it in Europe. And the goal for all EU countries to have to become smoke-free, that means less than 5% smoking rate by 2040, exactly the same approach and vision that Bangladesh has set through the Prime Minister, with the current smoking rate in the EU being approximately 25-26% in the general population, and with having about 700,000 premature deaths every year in the EU caused by smoking. It's about 8 million premature deaths globally in the world. So a similar goal was recently set here in Bangladesh. Bangladesh has a smoking rate of about 21%, but it is predominantly a male habit. About 40% or more of the male population of men are smoking here in Bangladesh. So a very similar vision, but it's ironic that becoming smoke-free is still a vision, because we know what's going on with smoking. We know about the adverse effects of smoking for decades, for about 6 decades now. So initially in 1962, the first report by the Royal College of Physicians in the UK, and then in 1964 by the Surgeon General in the US, addressed the issue of smoking and the problems, the health problems associated with smoking. And for the past 60 years, I'm sure the population globally is well aware of the adverse effects of smoking. And tobacco harm reduction has been suggested as a long-term non-medical practice for many years. In 1991, Professor Michael Russell, who is considered the father of harm reduction for tobacco in the UK especially, but I would say globally, suggested that we could use nicotine in a cleaner form than tobacco cigarettes, and this may be even a lifelong habit as long as people stay away from smoking. So basically as a smoking cessation tool, but avoiding relapse. And this was suggested in 1991, so it's about 30 years ago. But what has happened since then? It's been 30 years since this first suggestion, which was published in a medical journal, basically. But we are seeing, unfortunately, and this is not only happening in Bangladesh, the situation in Bangladesh is very similar to the global situation, a growing, largely authoritarian and restrictive or prohibitory approach for nicotine, not for smoking, and that's quite interesting to see, up to the point of equating tobacco cigarettes and their risk with a much lower risk, as we know, combustion-free, so non-smoking producing harm reduction products containing nicotine. So it has become a crusade against nicotine instead of a crusade against smoking. Unfortunately, this violates the principle of risk proportionate regulation, and I'm going to talk about this later. And this is a clearly prohibitory agenda. And I think you already have a neighbor here in the region, India, which has followed this approach, a clear prohibition for the least harmful product, while the sales of the most lethal nicotine-containing product or products is still the case. This creates, as you understand, a paradox. On one side, you're talking about risk elimination, risk aversion by banning the substantially less harmful nicotine products, but on the other side, you allow the sales, legal sales of the most lethal nicotine products. I suppose no one can really understand the reasoning behind that. And the question is that science, and does it serve the purpose of properly communicating scientific facts, truth, and health risks to the society? And can this lead to a smoke-free society? Now, it's very important to differentiate the two terms, smoke-free versus nicotine-free. Unfortunately, many confuse the terms and the goals, and they equate smoking, as I said, with nicotine in terms of health risk. And unfortunately, we are seeing that among not only the society, non-experts, but among healthcare professionals. And we published a study in 2016, and we asked physicians in Greece about their knowledge and perceptions about nicotine, harm reduction products, and smoking. And one of the questions, there were many questions like that, we asked them to tell us what they think is the contribution of nicotine on smoking-related atherosclerosis and heart disease. And as you can see, about 80% of the healthcare professionals said that nicotine is an important, very important, or extremely important contributor in smoking-related atherosclerosis, and the same in heart disease. The same response was given when we asked them about smoking-related lung cancer and cancer in other organs. And it's very interesting because we know for many years that nicotine does not cause cancer, does not cause cardiovascular disease. Now, the difference between nicotine and smoke is critical because, yes, nicotine is dependent, is responsible for the dependence caused by smoking, but it's not only nicotine, it's also the behavioral aspect. But at the same time, we know that health organizations have approved nicotine use in medications, in nicotine patches, nicotine gums. But not only that, both in the US and in the UK, these medications, nicotine medications, have been approved for long-term, even lifelong use as smoking cessation aids if someone cannot quit or relapses after a short period of time without using these nicotine replacement therapies. And the reason why nicotine through medications has been approved for long-term use is because it is not a carcinogen, it has minimal, if any, effect in the initiation and propagation of atherosclerosis and heart disease. And of course, it's much, much safer than smoking, even if it's used for long term. So it is important to understand that the same pharmaceutical grade nicotine that is present in nicotine replacement therapies is also used in electronic cigarettes, but also in nicotine pouches, in oral nicotine products, non-tobacco products. The same pharmaceutical grade that is used in NRTs. That's extremely important, so it's basically the same nicotine. Unfortunately, smoking still after 6 decades remains a problem. Why? Because quitting is extremely tough. Quitting by yourself, which is the most popular but the least successive method of quitting, has a 5% efficacy when you look at 1 year after the quit attempt. Everyone has tried it. Many smokers have repeatedly succeeded, and a repetitive success means that they have repeatedly relapsed. I'm one of these cases myself too. Quitting by the use of medications, and we have the best approach is some oral smoking cessation medications. At best, the success rates are about 20-25%. When we look at nicotine replacement therapies, the success rate is less than 7%. And according to many scientists, the success rate is absolutely zero. And any success mentioned in the studies is coming from psychological support rather than nicotine replacement therapies. So, unfortunately, even though we have these methods, there are many smokers globally who do not want to take medications to quit. They don't want to visit a smoking cessation service, even though they can do it for free. They don't pay anything, neither for the visit nor for the medications. Why is this happening? Because when you ask smokers why don't they want to go and ask for help from healthcare professionals, the response is that they don't consider smoking a disease but a bad lifestyle choice. So they need to change their lifestyle and their habits. They don't need to treat any sort of a disease. They don't consider smoking the disease, despite the WHO considering that smoking is a disease. So at least with currently approved methods, including quitting by yourself, there are at least 8 out of 10 current smokers who fail to quit with currently approved methods. And before discussing about the prospects of harm reduction, we need to make it clear what harm reduction is, because many people think that harm reduction is just these nicotine-containing products that don't involve combustion, but harm reduction is a philosophy and a strategy that we follow daily in our lives. And characteristic examples of a harm reduction strategy is the use of seatbelts and helmets. That the use of seatbelts and helmets don't make driving a car or a motorcycle absolutely safe. They just reduce the risk. The only way to eliminate the risk is never to enter a car and never to drive a motorcycle. That's the only risk elimination strategy. But of course, we don't plan to ban cars or motorcycles, not even for recreational use, to go with our families for a trip. Harm reduction is also, and that might be strange for you, but medicine as a science is by definition a harm reduction science. And why is that? Because only some infections can be cured, and otherwise the diseases are treated. When someone gets a heart attack, part of his heart dies basically, and that part will remain dead for the rest of his life. We're not going to be able to revive it, so the disease will always be there. The patient is classified as a heart disease patient for the rest of his life. We cannot cure the disease, we're just treating the disease. That means we reduce the harm caused by the disease, we reduce the symptoms, the consequences, the decline in the quality of life caused by the disease, and we reduce inability. So this is a harm reduction approach. Medicine is by far one of the harm reduction sciences that we have. Now, one of the examples that has been mentioned, and I think will be mentioned quite frequently in our discussion, is the Swedish example. Why? Because Sweden is one of probably the only country in the world that has become smoke-free by 2023, not 2040. So 17 years earlier than the smoke-free vision and goal for the EU and for Bangladesh. That's quite an astonishing example of a country. But what have they done? You see here the comparison between the rest of Europe. It's an extremely low smoking rate. The next best example is the UK, which has followed the route of tobacco harm reduction and has substantially reduced the smoking rate in the last few years, but still they have not managed to reach the levels accomplished by Sweden. And what has happened in Sweden? There has been a transition from smoking to the use of harm reduction nicotine products. And as you see here, there has been a transition from smoking to the use of snus and nicotine pouches, but that is only in the last 10, 12 years. If you look further before, since the 1980s, there has been a huge transition from smoking to the use of snus there, because it has been a tradition to use snus, an oral tobacco product. And as you see in different age groups, from the 30+ % smoking rates, in mid 2000s, the smoking range went quite low, and there was a reversal compared to the rates of snus, which were lower in the 80s and grew up in mid 2000s. So in Sweden, they do have a high overall tobacco use and nicotine use, but it's not coming from combustible products. It's not coming from smoking. It's coming from non-combustible nicotine products. And here is a characteristic example. When you look at the latest Eurobarometer 2020, it's a survey performed throughout the European Union. When you look at the smoking rate versus nicotine use rate, and Sweden has the same nicotine use rate as the rest of the European Union, but a much lower smoking rate. So nicotine use, the same. The product through which they obtain nicotine is different. And what is the outcome of such an approach? Sweden has by far the lowest death rate attributable to tobacco compared to the rest of the European Union for lung cancer, for cancer in other organs, for cardiovascular disease, and for all-cause mortality. Almost 3 times lower than the median levels in the European Union. So it's not a problem of nicotine use, it's a problem of what product the population uses in order to get the nicotine. And the problem is coming from combustible tobacco cigarettes. And that should be the focus of the public health community. Now, one of the arguments that has been used against harm reduction products, and particularly electronic cigarettes and vapes, is the issue of flavors. Many people accuse the e-cigarette industry that flavors have been created and are marketed in order to attract kids. But I suppose that everyone understands, we are all adults here, that whenever we go to eat or drink something, we want to eat and drink something that has a very good taste. We're not kids, we're adults, but we like flavors. And that has been the case with adult vapers too. Very recently, a systematic review of about 100 studies concluded that there are 2 factors that address the appeal of e-cigarettes among adult, current and former cigarette and e-cigarette users. Among adults, it's high nicotine concentration and the variability of flavors. And of course, they reported the abuse potential for adults, but abuse potential for a smoker is a good thing. Abuse potential, as a scientific term, means that a person wants and likes to use a product. And as you understand, if you provide to a smoker an alternative product that no one likes, they're not going to use it. A characteristic example is nicotine replacement therapies. They are pharmaceutical products, they are absolutely safe, they don't provide any positive experience to the smoker, and no smoker is using them. The use is minimal, the success rate is also minimal. So we need to create products that are appealing to the smoker. And there are 2 factors that affect this appeal. It's the nicotine concentration, so getting enough nicotine, and of course, flavors. And that's why the authors concluded that higher nicotine concentration, the availability of a variety of flavors, may facilitate complete substitution for cigarettes. So the regulations should take into account the impact on smokers, and we don't want to punish smokers in order to supposedly protect other groups, and I don't think we will protect any group with prohibitive regulations. Now, we've also done some studies in the issue of flavors among adults, and we've seen that among adult vapers, most of whom were former smokers, so they were smokers and had quit with the use of e-cigarettes, we observed that the vast majority were using non-tobacco flavors, particularly fruit and sweet desert candy flavors in electronic cigarettes. So it's not a coincidence it's not a marketing trick for kids, it's a marketing tactic for adults because there is adult demand for flavors. And when some researchers in the US at Penn State University followed up vapers for 5 years to see how they changed their flavors choices over time, and all of them were adults, they saw that over the period of 5 years of follow-up, the preference for tobacco and menthol and mint decreased almost to half. The preference for fruit flavors remained stable, but for candy and sweet flavors almost doubled over this 5-year period. Interestingly, almost all of these vapers were using more than one flavor on a regular basis, and only 11% reported that tobacco was their preferred flavor. So all these who were adult vapers, many former smokers, they didn't want to use tobacco flavors. And that's why the researchers said that it's adults who also like electronic cigarette flavors and flavors in general. So what should regulators and politicians do? I think that they don't need to change their usual strategy when they apply regulations for any product. The main principle that regulators use when creating legislation for regulatory purposes is a risk-proportionate regulation. And considering the totality of evidence that these products are by far less harmful than smoking, there are a few key steps that the regulators can take. First of all, they can create some quality standards that are, of course, not very complex and not very expensive to ensure product quality for the consumers. Second, they should promote these harm reduction products, as New Zealand and the UK is doing in several other countries now, to the intended populations, to smokers and former smokers. And they should create appropriate regulation to ensure that marketing is targeting these populations. Of course, they should maintain a competitive advantage for harm reduction products compared to smoking. And that's in terms of price, availability, and accessibility. Again, I'm going to repeat the paradox of allowing the legal sales of the most lethal product, which is cigarettes, the most lethal nicotine-containing product, and restricting or banning the least harmful products, such as electronic cigarettes, nicotine pouches, and other oral nicotine products, and heated tobacco cigarettes. It doesn't make any sense. There is no reasoning behind that. It's an irrational approach that we should make sure that the regulators understand how paradoxical and irrational it is. So, and of course, we need to promote research to the population and develop better or even safer products, but you need to allow the products in the market in order to do that. Harm reduction products, I will emphasize, they need to be appealing to the smoker. Otherwise, no one is going to choose them, no one is going to try them, they will just keep on smoking. So the regulation should be reasonable, risk proportionate, realistic, simple and easy to implement. We don't need highly complex regulations that no one can really enforce. And of course, it should be different from the regulation of tobacco cigarettes. And because of the risk proportionate principle, of course, different means less restrictive. Less restrictive. So in a realistic world, because we have the idealistic world where we will tell smokers tomorrow to quit and everyone is going to quit, you understand that this is not going to happen. And by setting goals like the EU or even Bangladesh of a smoke-free vision for 2040 without saying how we will achieve this smoke-free vision, these are probably nice words, but with no content. So we need to create the rules and the ways of achieving the smoke-free world. And we need to be realistic. So in a realistic world, the public health benefit cannot be achieved by finding the safest option that probably very few or no one will want to use, but the important thing is to strike the right balance between lowering the risk and having a very popular product that smokers are willing and would like to use. Nicotine, in a cleaner form and not through tobacco cigarettes, can be a very effective harm reduction tool as long as I said, it's not obtained through smoking. And in my opinion, this is what will accelerate the decline in smoking, which is not going to happen in one day, of course. We need to be realistic. It's going to take time. In Sweden, it took 30 years plus. It's going to take time, but if we don't start, we will never reach to the smoke-free vision. Thank you very much.
Konstantinos, we have one question before we
Yes.
go to Mihaela, who's answering, and you'll be on the panel at the end of our summer day.
Yeah.
You made the profound statement that the total nicotine intake in Sweden remained the same, but that the delivery system had changed.
Yes.
In Bangladesh, would you anticipate that the same could happen?
Oh, yes, and Bangladesh is also one of the countries with a high rate of oral tobacco product use. And I don't have any experience for Bangladesh, but I know in India they are using some highly toxic oral tobacco products, highly carcinogenic. India is the #1 in the world in terms of oral cancer. I think that the prospect of all these harm reduction products, whether it's inhalation or like electronic cigarettes, heat tobacco products, or oral nicotine pouches, is tremendous, especially in countries where there is limited availability of smoking cessation services. So many people argue that in countries with no organized tobacco control and smoking cessation efforts, discussing about harm reduction makes no sense. I think what's the case is the exact opposite. In countries like Bangladesh, where smokers have very limited choices to quit smoking and get help to quit smoking, these are the countries where tobacco harm reduction is going to have the highest impact, because the government doesn't need to invest anything in creating services. Tobacco harm reduction is self-funded by the smoker. They just need appropriate, reliable, balanced, and unbiased information in order to understand the vast difference in the risk between the lower risk nicotine products and tobacco cigarettes. And if they do that, they will fund by themselves their effort and their attempt to quit, and many will succeed. So I think that the prospect of harm reduction in countries like Bangladesh is much higher than the prospects in the European Union, to be honest.
Friends, join me in giving Konstantinos a warm
Thank
round
you.
of applause. Thank you. Schumann, especially when Konstantinos was mentioning the role of flavors,
Yes.
you were nodding your head, and I would suggest that in the last panel that we revisit this particular topic because of the impending ban in other countries like Canada of flavors. Thank you very much, Konstantinos. It is now our pleasure to welcome online Professor Mihaela Arescu, who is Professor of Oral Health and Dentistry in Bucharest, Romania. We shall first play a short clip, and then Mihaela will join us online for some live questions.
In oral health is something very interesting, because every time we think that the first place where the smokers might have some, let's say, changes, it's exactly in the oral cavity. Usually we can find some discoloration, halitosis, everybody can see a carie, everybody can see if we have a missing tooth or something which is very, very visible. So in oral health, it's quite easy to note every changes, and all the people around us might see exactly what I'm telling you. So usually in oral health, we can find the differences between a very nice and clean and healthy oral mucosa if you are a non-smoker and a healthy person, and also we can find the difference if you are a smoker and a cigarette smoker especially. I made some let's say research, and I made some studies about how we can change the oral health aspect. I mean, if we can switch, I mean, if the cigarette smoker is switching the cigarettes with some other alternatives, let's say a heat-not-burn products or some other nicotine products without burning. So I saw that the patient may have some good changes in their oral health. That means I found after 9 months of switching that usually the bacterial plaque is less. That means less gingival inflammation, and also that means less halitosis, and also that means a better health in the oral cavity. Also, if we want to make a treatment with implants, and let's think about sometimes every one of us and or somebody from our family might need an implant treatment because this is the life. Usually, if the patients are smokers, we have to inform them that in the period of osseointegration, that means immediately after the first step, meaning surgical step, they have to quit smoking just at least for 3 months. So this is very difficult for somebody who wants to, who tries to quit smoking and it's a very long time smoker. And we have to, I mean, it's much easier for them to tell that they have an alternative. Otherwise, they will say, I cannot quit smoking in this period.
Mihaela, thank you so much. If we may just welcome Mihaela to us, and if we can give her a warm round of applause, all the way from Romania. Mihaela, thank you for your words and what sticks, and you probably heard Constantino speaking about the potential benefits of tobacco harm reduction to oral health in Bangladesh. If you were the advisor to the Ministry of Health in Bangladesh, how would you advise them with concerning acceleration of the benefits of harm reduction products vis-a-vis the continued use of cigarettes?
Thank you, Delon, and hi, everyone. I'm thinking that, in my opinion, the most important thing is that the doctors have to be informed about the alternatives that the cigarette smoking. I mean, what kind of alternative a smoker can use if they cannot quit. They are willing to quit, but they cannot. And I think that the doctors may inform the patients, because I'm sure that the dentists in Bangladesh are working in the same way like we are working all together. So they have a lot of patients. The information coming from a doctor is always a good advice. And if the doctors are well informed about this, they can give the information to their patient, so the patient will have a very well-informed choice when they decide to change and to switch from a cigarette smoker to some alternative user. And this is the main point. I don't know if the doctors in Bangladesh are aware about the alternatives. We all use alternatives in many fields of our life. Let's say sweetener in diabetes patients, or let's say powder milk in breast milk if we want to change, I mean to switch to from the breast milk to some powder milk if we cannot use the breast milk. So we always use some alternatives. Innovation is the common word for all these alternatives. And we are always, let's say, involved in finding some other alternatives if we cannot do something that we need, or if we we cannot use a product. So we always try to find an alternative. So this is my my advice, to not demonize the alternatives if we think about tobacco. And tobacco harm reduction may be applied if we keep in consideration the results of the research
about the risk-reduced products when we speak about, let's say, heat-not-burn, e-cigarettes, snus, and some other pouches and some other products, innovative products that are now in the market.
Thank you, Mihaela. And could you please, we have 7,500 members of the Voice of Vapors in Bangladesh. And one comment you made was that the mouth is an easy place to see both the damage of cigarettes,
Yes.
combustible tobacco, and also a very good place to measure the improvement. So in your own clinical experience, when a patient quits smoking or switches to a smoke-free product like vaping or oral nicotine pouches, what are the immediate changes that that consumer or patient would feel or undergo?
Okay, the immediate changes is the consistency and the color of the bacterial plaque. That may appear very quickly. I mean, we can see it, even if you are not a doctor, you can see it because you can take a look in your own mouth, like seeing exactly what's happening. The discoloration is less. The inflammation of the gingival inflammation is less. So that means less microbial infections in the oral mouth. Also, if the halitosis decreases, also this is also a problem when you are a cigarette smoker. The halitosis, the pH, but the pH it's quite difficult to examine, let's say, if you are not a professional. But as I told you, the bacterial plaque, the discoloration, and the halitosis are the first signs that you can easily see when you switch the products from the cigarette smoker to some other product, for example, from heat-not-burn, as I studied.
Two more questions, please, Mihaela. So what is the role of research to quantify and qualify the benefits of tobacco harm reduction as you've just explained? Is there a role for further research in oral health?
In my opinion, long-term research is a very good thing because we can have more valuable results. But anyway, the only argument that we have when we speak about the difficulties to use the other alternative products, the only argument is that we have the results of the research, a good research, a well done research, clinical research. I'm thinking that it's important to follow these results, and it's important to have long-term studies, because usually short-term studies are giving just the first step of our explanation, but a long-term research will focus exactly on the effects on long term.
Thank you, Mihaela. And then something worrying that you said was that health professionals, doctors, and even dentists do not tell their patients or the consumers of cigarettes the benefits of quitting or switching to a smoke-free alternative. How can that be rectified?
The doctors are themselves smokers. Many doctors are smokers, cigarette smokers. In my opinion, maybe they are not aware about the different alternatives that they may use, and I think they don't speak too much about the alternatives. They don't speak too much about smoking. They are only aware of the bad effects of cigarette smoking. And because they don't speak too much, they are not, I mean, they can read the literature, the specialty literature, but I don't think they really are informed about this, because usually they are focused on the damage of the cigarette smoking and not on the alternatives. So that's why I'm saying always that if the doctors are informed, and if in the conference they can have this kind of information, they will know exactly what to, I mean, if they are convinced that it's a good thing to switch, after that they will explain easier to their patients how they can do, how they can have an alternative if the patient if they want to quit and they cannot. Because let's face something very easy to observe. You tell to your patient, please don't smoke after an extraction. And what they are doing immediately after they leave the office, they said, okay, doctor, I was stressed, so I want to have a cigarette very soon. So this is the problem. They don't have, the patients are not having alternatives. The doctors are not telling them, look, you can have this alternative in case you are exactly willing to quit, but you cannot. And this is the reason I think that's happened. The doctors are not informed.
Thank you, Mihaela. One last question. When we advocate for tobacco control and the role of harm reduction, we talk about we save lives.
Yes.
Is it fair to say that we're also saving teeth? Would a consumer who stops smoking cigarettes and switches to a harm reduction product be more likely to retain a full mouth of teeth than one who keeps on smoking?
If we think that, if we just think about the fact that smoking means to have more inflammation, more bacterial plaque, and a very acid pH in the oral cavity, that leads to, that means in time, the oral cavity will be affected. So that means the inflammation may affect the dental support in the ligaments and the periodontal structure. So yes, in time we can take a look of if we have a lot of smokers around us, we can take a look of their mouth. It's just I can say that for my professional point of view, every smile is a sign about the general health of a person. So if we take a look of a smoker mouth and their smile, only their smile, we can understand immediately how it will affect in time the smoking, how it will affect the oral health, the smoking. How the smokers are having different problems, easily observed by looking. Like it's not a very difficult thing to do. So yes,
thank you.
yes, of course, you can lose teeth. After that, you have to pay a lot to make dental treatments, and it is not something pleasant.
There you hear it, Schumann, from the professor's mouth.
Yes.
We're not only saving lives, but saving teeth.
Teeth as well.
Please, could we give a warm round of applause to Professor Resto?
Thank you. Thank you very much.
Thank you.
Thank you, Mihaela.
Thank you very much, Professor Dr. Konstantinos Varsalinos and Professor Dr. Mihaela Raiscu for that wonderful session. The next session will focus on the topic harm reduction as a human right and the role of health professionals, where Dr. Kiyosi Litlapi will speak about role of health professionals in tobacco control to ensure access, affordability, and acceptance of harm reduction strategies. Dr. Kiyosi Litlapi is a former chairman of the board of the South African Medical Association and a former president of the World Medical Association. Due to some unforeseen circumstances, he couldn't be here with us and thus will be joining us online.
Good morning. I hope you can hear me.
Yes, we can, Josie, and we are particularly impressed by your shirt.
My apologies for not being there physically due to unforeseen circumstances, visa problems. And thank you for being invited to contribute to this discussion. Firstly, a disclaimer that I'm an ophthalmologist by training and a health activist by choice. And some disclosures that I consult to all industries that cause potential harm to human life. That includes tobacco industry, food and beverage industry, and I'm a health advocate, and I put patients first. Now, when it comes to the issue of the role that physicians can play in this, with respect to tobacco harm reduction, it's a very difficult role because of the miseducation of physicians on this subject. When you look at our training, the sum total of what we are taught about tobacco is the fact that if you smoke, you must quit, otherwise you're going to die. Most of us can't even recognize the symbol of nicotine if it was placed in front of us. We can recognize other things, a Krebs cycle, ethanol, but that which causes 8 million deaths annually, we know very little about. And our total education basically is indoctrination in 2 sentences. If you come into a doctor's room, they will ask you about whether you smoke or not, how many cigarettes, and the advice you'll get is quit or die. Very little information. And part of it is because that's all that we taught. You know, sometimes people think we doctors are special. We just the sum total of our training. We learn from those that are in front of us. We learn from what is put in front of us as subject matter. And on other subjects, we're well taught to be able to have open minds, to look at issues, to ask questions, and to act in the interest of the patient, to look at scientific data, to look at proof of what happens, to look at both sides of the story, to look at clinical trials, etc., etc. But when it comes to tobacco, none of that. And I think part of the issue that we need to go back to is what Derek spoke about, the FCTC, which is great to regulate combustible cigarettes. It was designed for that. It does not fit any of the other products that have become available in the last 15, 20 years. So what needs to be done in terms of making physicians useful in the fight against diseases caused by tobacco-related products is proper education on these issues. We also need to ensure that there's an environment where there's open studies and truthful reporting. We've seen the challenges of EVALI, the challenges of misinformation, the challenges of untruths that come from our sector as healthcare professionals, where we confuse the public. Konstantinos spoke about the fact that in a study conducted in Greece, doctors were ignorant about the difference between what causes cancer in terms of tobacco-related products. There's misconceptions about nicotine. And what is frightening is the fact that we as doctors have accepted nicotine replacement therapy. And if nicotine was harmful, how could we be promoting supply of nicotine to patients if it is that harmful? So the point that I'm trying to make is that the role of physicians will need to address proper training and proper education on tobacco and how the harm comes from tobacco-related products. And unless you address that miseducation, it is difficult to have healthcare professionals, in particular doctors, play a meaningful role in education of the community. We also have a huge challenge coming from the role of the World Health Organization on this matter. And that's going to be critical in addressing the issue of saving lives in tobacco-related deaths. And I think the FCTC is a great instrument for combustible cigarettes. But the other issues, the WHO has not been exemplary. If you go to the Swedish example, the WHO has supported and recommended banning of snus in all countries. Sweden got an exemption because they had modified a product that they've been using for over 200 years. They put it in a sachet. And it's interesting when you talk about snus that the issue of putting the loose tobacco into a sachet was an issue of hygiene and convenience to a user. A scientist who was a pipe smoker, who was disgusted by the hygiene habits of loose tobacco, decided to put it into a sachet. And 40 years later, you've had the tremendous public health benefits of snus in that community. But the WHO has banned snus, despite the Global Health Report of 2020 showing the fact that the Swedes have less tobacco-related diseases, largely because of snus. The WHO has not seen fit to reverse that decision. We've seen even countries going into notions of banning nicotine pouches, pouches that don't even have tobacco. So we really need to address the role of the WHO in relation to tobacco use. And the fact that there are alternatives to combustible cigarettes, and we need truthful reporting on the effects of the alternatives to combustible cigarettes. What cannot be supported is to have a structure like the WHO encourage bans on less harmful products and awarding people, giving people, honoring people like the Minister of India who banned vaping products. Now, that is a key issue because a lot of the healthcare professionals and healthcare systems, particularly of low and middle income countries, are dependent on what is recommended by the WHO. In a sense, the WHO is like a Bible reference with respect to health matters. And it is important that the WHO continue to be an organization that is trusted by all. But it then needs to promote policies that is based on science, not morality, not rhetoric, not the past. And as has been discussed by Derek, the issue of engagement of all parties is critical. What happens in health circles is that any healthcare professionals that engage on this subject, that speak to the industry, are ostracized in the profession. That is unhelpful. That is something that needs to be dealt with decisively. In all other matters, when there is something that causes harm to society, all concerned, those affected by the problem, those causing the problem, governments, NGOs, we all sit around the table to find solutions. Tobacco should not be the exception anymore. Article 5.3 should be properly interpreted. Conflicts of interest should be properly managed, but everybody has to be around the table. I speak about these issues because amongst healthcare professionals, when people hear that you are engaging in tobacco harm reduction, they think you've lost the plot. They think you're crazy. When they hear that you are even prepared to talk to the tobacco industry, people think you should be crucified for doing that. Now, that is an environment that needs to be improved. You'll see behind me, as I speak to you, is the face of Madiba. And one of the issues that I always cherish about Madiba is that we have the dispensation that we have in this country, because Madiba was bold enough to say, you have to talk to the enemy to find solutions. If you are in a war, if we look at the issue of the Russia-Ukraine war, the only solution lies in mediators having Russia and Ukraine in a room with all other participants to find a meaningful solution. When there is a problem, everybody needs to be in the room to find meaningful solutions. That is going to be critical going forward. And once we do that, we'll create an open environment for scientific learning. If you contrast what is happening in tobacco with what is happening in the dagga field or cannabis field, as everybody wants to call it, you see that the things have happened in reverse. In that field, people have discovered that the cannabinoids are fine, but certain products of the dagga plant are harmful to society. But we are promoting the beneficial use of cannabinoids. The same thing with tobacco. Certain byproducts of combustion of tobacco are harmful, but people are looking for the nicotine, and nicotine has benefits. You know, people who smoke are not stupid. If there were no benefits to smoking, they would have stopped long time ago. Now, our duty as physicians is to educate. But on this battle, using my lens from having been in the battle around HIV and AIDS, in our country, where we had the highest number of people living with HIV in any country, we probably still have. The change was when people living with HIV and AIDS informed themselves and decided to fight for their own rights. The patients were more informed about HIV than the doctors. They used to come and inform doctors about latest trends, latest treatments, and they formed a partnership with doctors where doctors would go out and inform themselves. Because there was a lag in terms of information, knowledge, practicing doctors to what they knew. HIV came after most of us left medical school. Courses were designed to bridge the knowledge gaps of doctors. What we need to put in place, because of the knowledge gap that we have, or the ignorance that we have about tobacco products, is to come up with a course that teaches and informs healthcare professionals about nicotine and nicotine use and the harmful effects of combustion and the difference between getting your nicotine through combustion and getting your nicotine through non-combustible use. But importantly, the key to reducing deaths is to educate the people who smoke themselves and to educate the communities. Remember, when you have a person that smokes, the effects are not just on the smoker, they are also on those that don't smoke. You know, I'm a son of a father who used to stock up on cigarettes, who used to have a pipe, who used to smoke in the car. So I have been a passive smoker for most of my young days. So I understand those issues. And in his later years, my father on his own moved to smokeless tobacco and used snuff. But he has used cigarette for so long that, you know, he went to sleep one day and never woke up. So all of us are impacted upon by the effects of tobacco. The smell in our home, the smell on clothes. And when he went to snuff, things changed. So we must not be unmindful of the benefits to general society of moving away from combustible cigarettes or the dangerous forms of loose tobacco that we have today. So my plea is not just for the re-education of healthcare professionals, but also for the education of people who smoke and society in general. And lastly, I just want to touch about the fact that for those of us who are medical professionals, we got to be consistent. When we do not know on any subject that we do not know, we confess to our patients that we have no knowledge on that. we refer them to someone that would have better knowledge on this. But when it comes to tobacco, we have a license to be unethical. We have a license to advise on matters we know very little about. That traditionally is called unprofessional conduct. But when it comes to tobacco matters, that is condoned and that is basically promoted. We need to ensure that that is eradicated. Now, to our Bangladesh colleagues, there are three things that are important. We need to ensure that people who smoke have access to alternatives. We need to ensure that the alternatives are available to everyone. And more importantly, we need to ensure that they are affordable. Part of the challenges that we have in LMICs is that it's the poor segments of our community that are nicotine dependent. There's a high prevalence of use of combustible cigarettes in people that have less economic means. It is an ethical duty to ensure that the alternatives are not only available, but they are also affordable. And I'd just like to leave you with a statement that we need to ensure. We know that harmful effects of tobacco use or smoking are in the hands of people who smoke. Now, to reduce those harmful effects, we can only do it if we ensure that the alternatives are as readily available for people who smoke as combustible cigarettes or loose tobacco. If we do not do that, we are acting irresponsibly and we are complicit in not being enablers in reducing preventable deaths from combustion of cigarettes and use of loose tobacco that is unrefined, unpasteurized, and delivered directly to the oral cavity. Thank you. I'm happy to engage afterwards. And I'm just sorry that I couldn't be with you physically.
José, it's a pleasure to see you. And let me just tell you a story. José was asked by the man behind him, Nelson Mandela, at the height of HIV/AIDS, there was also an issue of access for HIV patients to antiretroviral therapy. They couldn't access the therapy and it was unaffordable, basically. Nelson Mandela asked José in a retreat to come and brief him one-to-one, man-to-man, on the background on HIV/AIDS and the need for access to therapy for HIV patients. So, José, a question to you. Are there any similarities in tobacco harm reduction where, in Bangladesh, the Voice of Vapors members and vapers in general face an impending ban, no access to vaping products? What would your advice be to the Prime Minister and the leaders of Bangladesh to make sure that the 3 A's are looked after: accessibility, affordability, and acceptance? What would you advise the government?
I would advise the government that bans don't work. In actual fact, when you ban stuff, you are abdicating from your responsibility to protect society because you are leaving people to be on their own. You are driving the matter underground. You are impeding the scientific world from researching on that subject because it's a banned substance and it becomes, you cannot engage in researching and creating better understanding of that subject. To go back to our HIV dilemma, we had a government that at the time prohibited provision of ARVs. We had people that went out to vilify ARVs as toxic, as harmful to the body, when it reduced harmful effects. And once we accepted ARVs, we reduced the numbers of preventable deaths in our society. So my advice to the government is prohibition is not helpful. You know, you look at Nelson Mandela, he was head of a movement that was banned, and South Africa suffered. When those movements were not banned, we were able to get around the table and discuss. So banning does not protect society. Because when you ban, you cannot regulate. The only way you can protect society is by ensuring that you regulate. When we look at alternatives, there are electronic products. There's issues about safety. There's issues about levels of nicotine that need to be in there. When you ban, you disable yourself from being able to ensure that the products that are in the market are safe products that can be used by your people. Bans do not work. Get everybody around the table. And as a government, do not take sides on a subject matter you do not know about. Get all the people that have different opinions around the table. Because as a prime minister, you are prime minister to all of them. So take a responsibility to put all of them in a room, force them to come up with a consensus on this issue, regulate on the basis of what you know, not what you do not know. Commission research for the things you do not know and the gaps that you have. That would be sound laws and sound regulation that is based on what you know and not on fear.
Khosi, on the ban issue is obviously extremely important in Bangladesh. And if I may, as a last question, during the COVID pandemic, South Africa and its government were, I think, one of 3 governments in the world that actually banned cigarettes and vaping products and any nicotine-containing product except for nicotine replacement therapy. What were the actual intended and unintended consequences of that ban?
The unintended consequences were the fact that there might have been an initial decrease in people that tried to quit. But because they are nicotine dependent, they found alternative sources. So what eventually happened is that the illicit market was promoted. The illicit market thrived. Prices went up. And the government lost essential revenue. So at the end of the day, what happened was the prevalence of smoking didn't go down. In actual fact, there was a study that was done not so long ago that shows that the prevalence of smoking in our society has gone up, not down. But what happened with the ban, you promoted illicit product, you lost revenue as government, the legitimate companies that pay taxes and provide jobs suffered. And all you did was to actually deprive legitimate businesses of income, deprive government of revenue, and increase prices to smokers without decreasing uptake, and promoted the illicit market. That's all that you did. And it reminds me of the fact that I've always spoken of 3 addicts, that smokers are addicted to the nicotine, governments are addicted to the revenue, and the tobacco industry is addicted to the profits. Now there are 2 more addicts. Public health is addicted to public health rhetoric, and harm reduction advocates like ourselves are addicted to the fame that you might get from harm reduction. So all of us need to be mindful of the fact that we are addicts of one type or another. And we all need to meet at the table to say, how do we ensure that the most important people, which is the public and people who smoke, how do we reduce harm to them on issues where you cannot stop us from taking things into our body? Just like Constantino spoke about, you can't stop us from driving. How do you make it safe? You can't stop us from eating. How do you make it safe? There are people that love their nicotine. How do we make it safe for them?
Friends, join me in a round of applause for Dr. Khosilet Lape. Thank you very much, Khosi. Friends, that brings us to the end of this first session, where we first looked at the history of the Framework Convention on Tobacco Control, and we had first-hand accounts from one of the architects of that framework, and then he applied the principles of harm reduction and gave advice to countries like Bangladesh on the policy making within tobacco control and harm reduction. Then we had excellent sessions by Mariva bringing New Zealand as a best practice model of a country that is now embarked on and adopted risk proportionate regulation. Konstantinos, in his inimitable way, gave us like an encyclopedia of the most important scientific background and evidence, the backing for tobacco harm reduction, and we are most thankful for that. And then you've heard from Mihaela and from Josi how important it is to include health professionals and for consumers to pursue the 3 A's of affordability, access, and acceptance of those smoke-free products that will give them a way out of combustible tobacco. Thank you for this marvelous first session. We will now have a coffee break and have some time to have discussions with one another, and then we'll come back shortly after past. Thank you very much. A round of applause to all the speakers again.
Wonderful. Josi is so interesting.
So far, so good. So after the...
I'm still on, microphone is on.
প্রতি বছর হৃদরোগ এবং ক্যান্সারের কারণে সর্বাধিক মৃত্যু ঘটে। প্রধান কারণ ধূমপান। যুক্তরাজ্যের মেন্টাল হেলথ ফাউন্ডেশনের মতে নিকোটিন ব্রেইনের নার্ভগুলোকে তাৎক্ষণিকভাবে শিথিল করে। এ কারণে অনেকে মানসিক চাপে থাকলে ধূমপান করেন, অভ্যাসবশত অনেকে করেন, কিন্তু বাস্তবতা হলো ধূমপানে দীর্ঘমেয়াদী দুশ্চিন্তা কিংবা বিষণ্ণতা কমে না। তবে হুট করে ধূমপান ছেড়ে দেওয়া অত্যন্ত কষ্টসাধ্য। অধিকাংশ ক্ষেত্রেই কিছুদিনের মধ্যে এই অভ্যেস আরও বেশি করে জেঁকে ধরে। তাহলে ধূমপান ছাড়ার সবচেয়ে কার্যকরী উপায় কি হতে পারে? এখন পর্যন্ত সবচেয়ে কার্যকরী পদ্ধতি হলো ভেইপ বা সিগারেট ব্যবহার করা। জাতিসংঘের এসডিজির অন্যতম সমর্থক ইউকে হেলথ সিকিউরিটি এজেন্সি, যা পূর্বে পাবলিক হেলথ ইংল্যান্ড নামে পরিচিত ছিল, তার গবেষণায় প্রমাণিত যে ভেইপিং সাধারণ সিগারেটের চাইতে ৯৫% কম ক্ষতিকর। কারণ সিগারেটের সবচেয়ে ক্ষতিকর দিক হলো টার, যা তামাক পোড়ানোর ফলে সৃষ্টি হয়। ভেইপে প্রধানত নিকোটিন, প্রোপাইলিন গ্লাইকল এবং ফ্লেভার থাকে, যা তাপের সাহায্যে বাষ্পে পরিণত হয়। ফলে এর থেকে টার তৈরি হয় না এবং এ কারণে শরীরে বিষাক্ত কেমিক্যাল ছড়াতে পারে না। ভেইপিং থেকে সেকেন্ড হ্যান্ড স্মোকিংয়ের সুযোগ নেই, ফলে অন্য কেউ ক্ষতিগ্রস্ত হয় না। যুক্তরাজ্যে ধূমপানের হার কমানোর জন্য অতি সম্প্রতি ১০ লক্ষ ধূমপায়ীকে কুইটিং টুল হিসেবে ভেইপিং কিট প্রদান করার সিদ্ধান্ত নিয়েছে তাদের সরকার। তাহলে আজও সবার হাতে ভেইপ কেন পৌঁছে যায়নি? এর একটি বড় কারণ ভেইপিং কি তা অনেকেই জানেন না, আর যারা জানেন তাদের ধারণা ভেইপিং একটি অত্যন্ত ব্যয়বহুল অভ্যাস এবং বিলাসিতা। অথচ খেয়াল করলে দেখা যাবে সিগারেটের দাম প্রতিনিয়ত বাড়ে। পাশাপাশি ধূমপানের কারণে ক্যান্সার, হৃদরোগ, অ্যাজমা, দাঁতের ক্ষয় ইত্যাদি বিভিন্ন রোগের চিকিৎসায় সরকারের ব্যয় হয় বিপুল পরিমাণ অর্থ। অপরদিকে বিশ্বের বহু দেশেই সরকারের আয়ের নতুন এক উৎসে পরিণত হয়েছে ভেইপিং। সেন্টার ফর ইকোনমিক অ্যান্ড বিজনেস রিসার্চের তথ্য অনুযায়ী যুক্তরাজ্য সরকার ভেইপিং থেকে ২০২১ সালে ৩১০ মিলিয়ন পাউন্ড আয় করেছে। এদিকে এগিয়ে আছে বিশ্বের আরও বেশ কিছু দেশ, যেমন ফিলিপাইনের কংগ্রেসে WHO প্রতিনিধি ভেইপিংয়ের সুফল সবার মাঝে ছড়িয়ে দেওয়ার জোর দাবি জানিয়েছেন। সম্প্রতি যুক্তরাষ্ট্রের চিকিৎসা পণ্যসমূহ নিয়ন্ত্রক সংস্থা FDA সিগারেটের সুফল বিবেচনা করে তা খোলা বাজারে বাজারজাতকরণের অনুমোদন দিয়েছে। এদিকে ভেইপিংকে সমর্থন দিয়ে বিশ্বে আলোড়ন তুলেছেন নিউজিল্যান্ডের সাবেক প্রধানমন্ত্রী জেসিন্ডা আর্ডার্ন। তিনি বলেন, দাম বাড়িয়ে ধূমপান বন্ধ করা সম্ভব নয়, বরং কোনো বিকল্প খুঁজে বের করতে হবে যা সিগারেটের চাইতে অনেক কম ক্ষতিকর এবং ধীরে ধীরে ধূমপানের অভ্যেস ত্যাগে সহায়তা করে। নিউজিল্যান্ডে ইতোমধ্যে ভেইপিং ফ্রেমওয়ার্কও তৈরি হয়েছে। সুইডেনে ১৫ বছরে ধূমপায়ীর সংখ্যা ১৫% থেকে ৫.৬% নেমে এসেছে, কারণ সেখানে ভেইপ, সিগারেট, স্নুজ ইত্যাদি ক্ষতিহ্রাস সহায়ক পণ্যের ওপর কর সিগারেটের তুলনায় মাত্র ৮ থেকে ৩৬%, যার ফলে যেসব ধূমপায়ী ধূমপান ছাড়তে চান তাদের জন্য বিকল্প পণ্য সাশ্রয়ী ও সহজলভ্য। এবারে বাংলাদেশের প্রেক্ষাপটটি দেখি। বাংলাদেশে যে কোনো ইলেকট্রনিক নিকোটিন ডেলিভারি সিস্টেম অথবা এর রিফিল আমদানি করতে 212.2% ট্যাক্স দিতে হয়। ফলে খুচরা মূল্য অনেক বেড়ে যায়। তাই ইচ্ছে থাকলেও একজন মধ্যম আয়ের মানুষের পক্ষে এদেশে সিগারেটের তুলনায় 95% কম ক্ষতিকর ভেপিং বা ই সিগারেটের খরচ বহন করা দুঃসাধ্য। যুক্তরাষ্ট্রের ভার্জিনিয়া ভিত্তিক কনজিউমার চয়েস সেন্টার 2020 সালে একটি প্রতিবেদন প্রকাশ করে। সেখানে তারা বলে, যুক্তরাজ্য সহ অন্যান্য উন্নত দেশে ভেপ বা ই সিগারেটের মান যেভাবে নিয়ন্ত্রণ করে, একই ধরনের মান বাংলাদেশে বজায় রাখা সম্ভব হলে 62 লক্ষাধিক মানুষ সিগারেট ছেড়ে ভেপ ব্যবহার করবে। অপ্রাপ্তবয়স্কদের উপর নিষেধাজ্ঞা, সবার হাতের নাগালে এনে দেয়া ইত্যাদি নীতিমালা তৈরি ও বাস্তবায়ন করতে পারলে 2040 সালের মধ্যে তামাকমুক্ত বাংলাদেশ গড়ার যে স্বপ্ন মাননীয় প্রধানমন্ত্রী দেখেছেন, সেটি সফল করার পথে আমরা অনেকটাই এগিয়ে যেতে পারব।